Rheumatic fever. Rheumatic fever is an acute, recurrent, systemic inflammatory disease, mainly of children, aged 5 to 15 years. Typically occurring 1 to 5 weeks after Group A streptococcal infection. Pathogenesis. Following exudative streptococcal pharyngitis, rheumatic fever occurs after 2 weeks. Various mechanisms proposed are direct toxic action by Streptococcus or its L form, lacking the cell wall, allergic reaction to the organism or its product, autoimmune reaction. There is similarity between the carbohydrate of the Streptococcus and some proteins of heart valves, causing the immune reaction. The clinical features of rheumatic fever are outlined in the Jones criteria and will be discussed in more detail in further videos. The various symptoms seen in patients of rheumatic fever include fever, swollen, tender, red, and extremely painful joints, particularly the knees and ankles, nodules, rash, usually on the chest, back, and abdomen, shortness of breath and chest discomfort, uncontrolled movements of arms, legs, or facial muscles, and weakness. Sore throat. 50 to 60% of people who develop rheumatic fever recall having a sore throat infection 1 to 2 weeks prior. Most streptococcal infections of the throat are caused by Streptococcus pyogenes, a group A streptococcus that also causes scarlet fever, rheumatic fever, and impetigo. Signs. On general examination, the patient may have fever and tachycardia. ECG shows sinus tachycardia, but it may also show prolonged PR interval, seen in first degree, second degree, or complete heart block. The following laboratory investigations are used. Throat swabs testing for cultures of group A streptococcus, although usually negative by the time the symptoms appear. Rapid streptococcal antigen test, RAST. Results are obtained quicker than for throat cultures, but may be less accurate. Anti-streptococcal antibodies. The most common antibodies found are anti-streptolysin O, ASO, and anti-DN-OSA-B. Blood tests. ESR and CRP, troponin, raised in myocarditis. Radiological investigations. Chest X-ray is done to rule out heart failure. Doppler echocardiogram may be used to aid diagnosis of carditis in acute rheumatic fever. Treatment. Conservative management. Rheumatic fever is one of the few conditions where bed rest is recommended as first-line treatment, even if the patient feels well. Especially in active myocarditis, limitation of exercise is strongly advised. Medical management of rheumatic fever comprises penicillin, which is the antibiotic of choice to kill any remaining streptococcal bacteria. A single stat dose of intravenous benzylpenicillin is administered initially, followed by oral penicillin B. Cardiac complications of rheumatic fever are worth mentioning separately due to their long-term effect on the quality of life of the patient. They include carditis, for example infective endocarditis, heart failure, pericardial effusions, valvular disease, especially the mitral valve, atrial fibrillation from severe untreated mitral stenosis, pulmonary hypertension, and thromboembolic events, such as strokes. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.